London Bridge Sports Medicine Podcast.
Welcome to the LBSM podcast. Today I'm joined by Samantha, who is a physiotherapist and the owner of Form 360 Physiotherapy. We're going to be discussing some of the top injuries in the strength sports, how they happen, and what can be done to manage them and ideally prevent them. So let me just introduce Samantha. Welcome, Samantha. It's lovely to have you on the podcast.
Hi, thanks for having me.
So if you'd like to just maybe introduce yourself to the listeners and give them a bit of background on who you are and what you specialise in.
Yes, so as you mentioned, my name is Samantha. I'm a specialist sports physio and I run Form 360. And the practice itself, we're a growing team of sort of diverse and multidisciplinary members, which is led by myself. We're very much about representation because representation matters across all aspects. And we treat elite to sort of everyday athletes alike. We use the same sort of high skills and techniques that we use to treat our elite athletes, to treat our everyday athletes as well, addressing across the board from mind, body, spirit. So the full 360 approach, that's the idea.
That's the idea. Great. So you obviously have a special interest in the strength sports. That's something that you personally are quite involved in.
Yes. So I am also an Olympic weightlifting athlete. So yes.
Which is amazing, absolutely amazing. So today, obviously, this is a topic that is very close to your heart.
Yes.
And we'll sort of get stuck in, I think, with some of the questions around injuries and in strength training. So are there any injuries that are most common across the lifting disciplines?
So yeah, when we really start to break it down, across the disciplines, there are some injuries that are more common than others, probably not the ones that you would expect, which I think we've sort of touched on before.
Yeah.
They can vary slightly in terms of joints that are affected. So, for example, I think commonly with both powerlifting and weightlifting, you would definitely see more knee and shoulder-based injuries. Also, occasionally some back injuries, and here and there, maybe wrists as well. Tend to see a lot of ankle strains and sprains in weightlifting or powerlifting. But with your more recreational lifting, commonly we tend to see it a little bit more in the way of, again, the tendonitis, tendinopathies, more the tendonitis. They're normally more acute. Actually, more back injuries with the conventional weight training or strength training, and occasionally more subluxations.
Okay.
So,
what, like sort of shoulder subluxations or?
Yeah.
Okay.
So actually, when I was really looking to sort of break it down to make it a little bit easier to explain, I think I would have grouped those into sort of four main categories, which is, as I said, your tendonitis, your tendinopathies,
Yeah.
your impingement related issues, and then also your compression related issues. And then at the very bottom of that, your sort of more strains, muscle strains, rather than sprains, but I would lump sprains in under that as well.
Yeah, I see. And is there a difference with regards to men and women in terms of those injuries? Do you see more of one category in men versus women?
Predominantly, no, actually.
Okay.
I think when it comes to this sort of level of training, because quite often when you look at training, normally those that end up in something like weightlifting or powerlifting have already had a taster in strength training and gained a sort of like for it. And that's where it's come from. Not always. But between men and women, there is the odd occasion. I think historically it's been alluded to, or actually not even alluded to, it's been spoken about that the Q angle has a huge impact.
Okay.
So obviously with the width of our hips in relation to them where our knees and our ankles sit below that. But actually that's become less and less spoken about. And I think the relevance of it has become sort of, but it's just less and less relevant because there are ways to still train the body to accommodate for that difference in women. I guess the other side of that is predominantly women tend to have hypermobility more often. So there is a slight increase in injury risk there, but then strength training in itself is such a wonderful tool for preventing injury risk in hypermobility.
Yeah.
I wouldn't say, again, there's this idea that men lift overall, the total load of weight that men lift overall is likely to encourage more or increase the injury risk. But again, pound for pound, that's not really the case in these sports anymore. So I think a lot of the classical ideas of where there's been a huge difference between men and women and injury risk in these strength-based sports, those have kind of been debunked. And a lot of that is to do with having a good coach and a good program as well. The main difference, I would say, that is potentially, still more of a common occurrence within women in strength sports is sometimes the leakage, so the pelvic floor stress.
Yeah. Okay.
Just because of the maximal exertion, basically.
Yeah. And I guess there's other sort of potential factors there with regards to hormones and that side of thing. And I know that there's quite a lot of research at the moment on sort of cycles and training and when you should be training more heavily and maybe within that cycle when you should be kind of easing off a little bit. So, and that's all really interesting, actually. It's something that's coming up more and more in women's sport.
Yes, it is. I would say more classically that applies to perhaps more of your contact sports. Like obviously in contact sports, we know at times when estrogen spikes, or perhaps actually whilst you're going through your period, there is a higher risk of things like ACL tears. The evidence absolutely does support that. With weightlifting, because it's a singular planar sport, so it's very sagittal plane, it's up, down, forward, backwards with powerlifting, for example, the injury risk across the board is much less actually than most of those high level or elite sports, if you like. There was an article that came out the other day literally with that title saying that it's actually one of the lower injury risk sports, which is really great to hear. I think where it can get very difficult with strength training versus some of these other sports, actually, there's such a huge psychological, there's a huge psychological element to all sports, but with weightlifting and powerlifting, there's such a huge psychological element to it that actually, if you lend your training a little bit too much or too rigidly to your cycle, it can actually have a negative impact. And there is other evidence being looked into at the moment as to how much of the changes in our cycle really truly affect our strength output. Yes, obviously there are times where we will have the feeling of sort of more fatigue, or we struggle with perhaps utilizing the energy from our food in the same way as well for training, or sometimes, we're dealing with brain fog and things like that. So that will impact our training. But actually, it's better not to, like I said, to heavily align your strength training with your cycle, because that can have a negative impact. So, and quite often, actually, some of the benefits, for example, of being a little bit more flexible during that particular time in your cycle can actually lend itself to you having a better lifting session, because with all the strength training that you do, especially with the lower body every day, it's very easy to feel sort of, stiff or tight. And actually, that little bit extra laxity allows you to have a better training session. It's all just about doing these things sort of, safely and within your limits, actually, is the key.
Yeah. Well, let's go into a little bit more of a deep dive with regards to some of the categories of injuries that you see. Do you want to kind of run through those lists of categories and maybe pick out some things that you think the listeners would be kind of interested in and would be useful for them?
Yeah, sure. So with the first one that I mentioned, the tendonitis or the tendinopathies, as I mentioned at the start, there is quite often more tendonitis within your regular sort of everyday strength training activities. And I would say there's probably a little bit more of a combination of tendonitis and tendinopathy within your weightlifting, powerlifting. So those that have been doing those activities normally for longer.
Yeah. Just break that down a little bit, just for our listeners. What defines a tendonitis versus tendinopathy?
Yeah. So to explain what the tendon is, that is a mass of collagen fibers which literally attaches muscle to bone. So that's what a tendon is. And in terms of tendonitis vs tendinopathy, the tendonitis is that very sort of acute inflammation. It's sore. You'll feel weakness. You'll become very aware of it. You may even feel a sort of loss in power in your activity because of the pain that you experience. So, for example, within the knees, quads, or patella tendonitis.
Yeah.
One you will feel slightly below the knee. It will be quite sore to touch or to put pressure on. You'll feel a restriction in movement because of the pain, for example, and you may feel that your power output is reduced because of that. It's quite similar with the quads tendonitis, but that would just be sort of above the knee as opposed to below the knee.
Yeah.
With the With the tendinopathies, These tend to be your more long-term conditions. So where there has potentially already been a tendonitis and it's calmed down, what we tend to see is there's normally some sort of disorganized pattern to the tendon if the doctors were to look at it under ultrasound, for example.
Yeah.
There can be like a thickening, there can be increased vascularity to the tendon, or there may be even some scar tissue where there's previously been like some small tears in it and it's healed, but that's become, like I said, sort of disorganized and it's healing. And what you tend to find with that is generally you'll wake up with sort of stiffness in the area. It will take a while for you to get going. But once you've warmed up and into whatever it is you're doing, things then become easier because the blood flow is increased to the area. It will still affect your power output. And quite often you'll find that the pain will sort of come back again after you've finished the training.
Yeah.
But it's not quite as acutely sore. It's more of that sort of dull, niggling, stiffness kind of pain. You just feel restricted and able to do what you want to do sort of freely. It's quite often, if I ask people in clinic, especially with the patella or quad tendinopathies, actually, can you do a squat now without sort of warming up into it? Or can you do a single leg knee bend without warming up into it? And they're like, it's that feeling
Feels
of those
quite
sort of
sore.
old knees, really. They're like, oh,
Yeah.
no, I don't think I could. If you give me 5 minutes to warm up, I'll be able to do it and I'll show you then. So yeah, I think the easiest way in clinic that I explain to people when really understanding why they occur, you have the loading tissue, i.e. the muscles,
Yeah.
and the loaded tissue, i.e. the tendons. And there's a disparity between those. And quite often within strength sports, it's a case of the loading tissue, i.e. the muscles, aren't really able to manage the loads, perhaps, or the loads intensity that you're doing within training, and that is causing stress onto the loaded tissue.
Okay.
And that's where, your tendinitises then become tendinopathies.
Tendinopathies.
Yeah.
And what is the best way to sort of manage these tendon problems?
So with the more acute tendinitis issues, a lot of that is actually activity modification, to be honest with you. So obviously we want to stop putting that tendon under that stress that we know is going to aggravate the tissue at the moment. So, for example, one of the easiest ways with a tendinitis actually is to perhaps reduce the volume of squatting that you do, maybe even consider lighter loads or eccentric movements, because when you get to this stage of training, a lot of people actually, they don't really want to stop squatting, for example. It's fundamental to their strength sport. So it can be quite difficult to get that balance. You also want to look at how do we reduce the inflammation? As I said, one is not stressing the tendon as much. And then two is looking at, do we need to increase the range of motion, i.e. lengthen the loaded tissue, the muscle? We can also provide blood flow via things in clinic. So obviously we'll do things like either acupuncture or massage. All of those things will help with, again, reducing the tension in the loading tissue.
Yeah.
And increasing that sort of positive inflammation through blood flow to the loaded tissue. So trying to ultimately reduce that inflammation. But yeah, most of the time it's offloading, allowing that to settle. We don't really encourage the use of anti-inflammatories, to be honest.
Okay.
Unless,
yeah,
unless it is something that you're literally every day you're struggling. So sometimes, for example, with the Achilles tendinitises, some people really are struggling to even sort of walk around on those. We don't get that so often within the strength sports, but then there would be a cause to
an
use
indication.
Anti-inflammatories so that you can at least manage the tasks that you're meant to do. With weightlifting, it's a little bit easier to try and offload it quite quickly, actually, because most of the movements will probably aggravate it when it comes to, quad or patella tendonitis.
Yeah. And those are the two that you see more of mostly, is it? The quads and the patella?
Yeah, yes. I would have said tendonitis wise, yes. We do
Okay.
still get golfers and tennis elbow as well
Yeah.
within both weightlifting and powerlifting. To some degree, with the shoulders, I would have said it's actually predominantly more tendinopathies. And I don't know if that is because people don't come in when it's a tendonitis of the shoulder. I'm not sure, but quite often it tends to be more tendinopathy.
Okay. So it's just got to that more chronic stage.
Yeah. I'd be
Yeah.
interested to
Great.
see why that is actually, to
Yeah.
ask more people.
Yeah. Why haven't you come in sooner? How long have you had? And what about things like shockwave? Do you use shockwave therapy at all on those tendons?
Yes, we absolutely do. So obviously, from a physio perspective, we like to try and manage these things as conservatively as possible.
Yeah.
So, we don't want to just jump on shockwave straight away. I think for those sort of very chronic tendinopathies, absolutely, like it makes total sense to use the shockwave with those. With tendonitis, not so much. And we tend to try and, go with the initial approach of, like I said, offloading, calming the tissue, doing whatever needs to be done to the loading tissues to try and support that, whether that's strengthening, stretching, etc.
Yep.
Any manual treatments for that. With the tendinopathies, to be honest, because you ultimately want to load them in order to affect the makeup of the collagen fibers and how that tendon responds to load, shockwave tends to be a very nice additional sort of adjunct to help that.
Yeah. Yeah. I had it once on my Achilles and it was really good actually.
Yeah, it
Um,
is really, really good.
it was
I've
quite
actually,
painful. I'm a bit of a wuss actually. It's not meant to be that painful, I don't think. I was like,
I think everyone experiences it
does it
differently.
differently?
Yeah, I
It was
think you're
quite
right though.
it is quite because my Achilles is quite tender, like,
Yeah,
being assessed, even just putting a small amounts of pressure on it was quite sore. So when you're kind
yes.
of doing the sort of shockwave, which is quite full on, yeah, it's
Yeah,
gradually.
I don't want to put anyone off of shockwave, but I
No,
will
no, I mean, it
say,
was amazing.
no,
It
no,
really
yeah,
helped.
it is amazing, but you're absolutely right. It does, for I have done shockwave to my own quad tendinopathy before.
Yeah,
And even that, which is an area that you would feel is sort of potentially got more sort of soft tissue there, it was
yeah.
still really quite sore. And I know one of my rugby players, she had the shockwave done as well. She actually had it done through the consultant initially and then returned to us to finish that off, sort of. And the first initial sessions, because it was a raging patella tendinopathy,
Yeah.
she said it actually made her feel sick
Oh,
because,
because it was
yeah, of the
so
intensity of it.
painful. Yeah.
But that is, I think to that extreme, that is quite rare and it just depends where it is. But it is uncomfortable, but it is also sort of revolutionary in terms of how it alters your pain and then also allows you to alter the tissue.
Continue with your yeah, exactly. Okay, so we've sort of focused on the sort of lower limb a little bit with that. You were also talking about impingement type conditions.
Yes, I do enjoy a good hip. So I think that the reason I lumped those together under that sort of impingement related issues is the next two most common would be your FAIs,
Yep,
and
which
off the back of that is labral tears. Sorry, carry on.
okay. Oh, which I was going to say is
Oh,
what it stands for.
yes, so that's a femoral acetabular impingement. So femoral as in the head of the femur, acetabular as in the socket of the hip, and the impingement between those two surfaces.
Yeah,
And then quite often that ends up leading to things like labral tears.
yeah,
And I have actually put
on there
under
as well.
this as well. Yeah. So shoulder bursitis is another common one that we see. So although I have put that under those impingement related issues, because it is an impingement related
Impingement, yeah.
issue, even though we don't use shoulder impingement as commonly as a diagnosis anymore, which I think is a great thing. I don't think we should be actually calling a lot of these issues shoulder impingement. We need to be a little bit more specific with what we're talking about is being impinged.
Yeah,
And bursitis for weightlifting, powerlifting does seem to fit within that
within that.
bracket.
And with regards to bursitis, again, obviously there's burses in around every sort of joint. So are you talking about hip bursitis or are you talking more sort of shoulder bursitis with that?
Yeah, definitely shoulder bursitis.
Yeah,
I would say actually hip and knee bursitis. Neither of those appear that often. If any sort of irritation to that sort of soft tissue within the knee, we'd probably be looking at more of a Hoffer's fat
that
pads
bad.
irritation rather than bursitis. That doesn't come up very often in
Okay.
weightlifting or powerlifting, but the shoulder bursitis does
Okay.
actually.
So just explain a little bit exactly what a bursitis is.
Yeah, so for example, within your shoulder, so it's very difficult to explain. if you can't see the picture,
Yeah.
but sort of under the hook of your acromion, so what we call your AC joint, where your clavicle and the back of your shoulder blade sort of come together and meet, the hook of your shoulder blade come together and meet. Within that space, which is just above the ball and socket joint, that's where some of your rotator cuff tendons travel through and connect. And to stop friction of those tendons and those bones against each other, or those tendons against those bones, you have a little sac of synovial fluid. So it's just, yeah, the easiest way to give somebody a visual is it almost looks like a small, like it looks like a water drop, that sort of shape in some ways. So the synovial membrane with the synovial fluid inside, which is mostly water, some hyaluronic acid, and some other proteins which I've forgotten.
And that, and it's to do, is that to do with the technique, would you say? Is that what causes that sort of to become impinged and then obviously inflamed?
Yeah, it's the biomechanics play a large part in it. So it could be to do with restriction. So over technique, it's actually whether or not you're able to get into that position. So that could be restriction at the shoulder joint or even at the sort of upper back, the thoracic, that won't allow you to create a nice clear space to the shoulder joint to move through when you're lifting. It can also be due to weakness within the surrounding muscles. I think commonly we always hear people sort of talk about, oh yes, my rotator cuff. Yes, enlarge the rotator cuff, but also those bigger supporting muscles. So for example, your delts, your rhomboids, your traps, your lats, how do they all play into your ability to control weight?
Yeah.
Overhead or in front of you. And then sometimes you can just be one of these unlucky people that maybe has a slightly sort of narrower space in there, or just a slightly different makeup of your glenohumeral joint or the whole shoulder joint complex, basically. But yeah, I think technique, we can adjust it if you are struggling with shoulder bursitis. We can adjust it to make sure that actually what you're doing isn't putting additional pressure on it. But 9 times out of 10, again, if you're going into these sports, you generally have a coach,
Yeah.
and that coach has generally sort of taught you from the ground up, really. The sort of technical element to it doesn't come into it so commonly unless you're perhaps either not being taught the correct technique or you're choosing not to how do I say this? How do I say this without upsetting people? But you're not allowing your ego to dictate how you move
Okay.
in a session, because sometimes people just care more weight, more weight, more weight. And that's a sort of very ego-based lifting. And that's where then you get failures in technique and then you get other injuries or niggles off the back of that.
Yeah. And do you, obviously you talk in terms of people who are doing this more professionally, often have a coach. In terms of recreational lifters who just are at the gym, I imagine this sort of problem is more common. Is that right?
The bursitis.
Yeah, or the impingement, especially around the shoulder.
Yeah, it can. I think across all of the strength sports, it can be, but for different reasons.
Okay.
And I would agree that actually with the more recreational sort of lifting, if it's generalized strength training,
Yeah.
yeah, quite often that is because they haven't necessarily had the input of someone to sort of say to them, actually, you need to be moving in this manner, or actually, you're not moving that weight well. Perhaps you want to reduce the amount of weight you're lifting, or, or you look
Yeah.
stiff in your upper back. Actually, if mobilizing this will help you to move better through the shoulders, for example. So,
Yeah.
yeah, I think it's common across all of the weight training sports, to be honest with you, but just for different reasons.
Yeah. And what is it? What are the movements that actually, or the specific? Because I know in each sport there are quite specific movements that you have to do and weights that you have to do. So, what is it that specifically makes that problem flare up?
Predominantly in weightlifting, it will be the snatch.
Okay.
That is the most intense movement on the shoulders, realistically.
Yeah.
And that's just due to the position. Ultimately, you're in an overhead squat with quite a wide grip on the barbell. So, in terms of shoulder intensity, it is pretty intense, actually. And that's why a lot of people coming into weightlifting really do struggle with the snatch, because the technical elements to it, where that meets also sort of mobility and strength, that is probably the most complex one to sort of progress initially.
Yeah.
Whereas your clean and jerk is very much more of a sort of strength-based movement. Predominantly, even with the jerk position overhead, your arms are only ever about sort of shoulders width, maybe slightly wider. So in terms of that being a position that I wouldn't say we would more commonly do necessarily in everyday life. We might do if we were lifting something up overhead into a cupboard. But in terms of anything you would do gym movement wise, that's a more common position for people. The snatch is quite different.
Okay.
With powerlifting, the only thing would be the bench, really,
Okay.
and the different ways in which you bench in powerlifting classically by comparison to perhaps your more recreational gym-based bench press.
Okay.
So, because there's a lot in that in terms of spinal flexibility, specifically thoracic flexibility, and then the more extreme position that your shoulder blades are sort of pulled into. It's a very retracted and extended position through the thoracic, because with powerlifting, technique-wise, it makes sense to have to move the bar a lesser range of motion to get more weight. So there is a bit of a tactic there. The better your arch through your thoracic, and the better you're able to sort of pin in your shoulder blades, the easier it is to move that barbell a short range of motion and still get the rep. So,
Okay, I see.
yeah.
And then moving away from the shoulder and back to the hip. Talking about hip impingements and labral tears, as you mentioned earlier, what are the movements that cause that to kind of become a problem?
Yeah. So, in terms of the movements, it will always realistically be the squat pattern.
Yeah.
And it's one that's classically not thought of being a cause of perhaps FAI or a labral tear. It's thought of being, more of a position that causes a symptom of one of those. Classically, we've always sort of thought of those sports like football or hockey or, anywhere where you're doing a lot of, like I said, multiplanar movement, especially from the lower body, as the sort of causes for those labral tears. But actually, one thing that I think gets overlooked very often with weightlifting is you have to be so dynamic. And this is where these tend to appear quite often more in weightlifting than they will in powerlifting, because in powerlifting, the squat mechanics are quite often different and they are compound movements. So they're very controlled, time under tension based movements. With weightlifting, that element is our strength training. And the actual lifts themselves are very dynamic. You're not only using your power to essentially, in crudest terms, launch a weight up. You're then trying to dive underneath it and catch it. So that bottom position is a very dynamic position. It's very high stress. And whilst we would hope that, we may manage to maintain perfect squat mechanics, actually that doesn't always happen. Maybe sometimes you catch this lift with a slightly wider base of support, or you end up leaning slightly more into one hip than the other. And so quite often that's where you will find then, because obviously the acetabulum and the femoral head, they're in incredibly closed position at that point, you will get these FAIs, so these impingements at the hip. And sometimes it is just that, a little bit of, a pinch, inflammation. And then quite often, I would say that a lot of the or not undiagnosed, but a lot of the hip impingements that are diagnosed as things like hip flexor strain or bursitis around the hip, they are quite often a labral tear.
Okay. Yeah.
So, yeah.
And the labral tear is obviously something that happens with repeated impingement.
Yeah. And that's why it's sort of, in some ways, it's inevitable with weightlifting, especially if you are one of these people that perhaps has an impingement from something like a cam lesion at your hip, cam or pincer, then you're already at a higher risk potentially of a labral tear happening just due to the physiological setup of your hip socket. Joint, I should say hip joint.
Yeah. So I guess, again, just highlighting what you've just said and breaking that down slightly. So very often with hip impingement, there is some underlying pathology or anatomical problem. So with the hip. So just explain that a little bit in a little bit more detail. You talked about cam and pincer impingement.
Yes. So I think in an ideal world, or how everybody probably imagines the hips when they look at them, is that classic sort of 2D X-rays type image of, you see the pelvis and you see the little cups and then you see the ball of the femur sitting into that cup. So yes, you have your femur with the ball at the top, and that ball at the top may not be the exact perfect shape that you've classically seen over and over again. There might be some slight changes to the shape in that ball. Maybe it's got a little bit of extra bony growth, or it's sort of, like I said, shaped slightly differently. That would be where we talk about something called a cam impingement. So impingements happen where there's a contact point between the acetabulum, which is the sort of cups that I was talking about that your ball fits into, and the ball from your femur. So with a cam impingement, if the top of your femur, your ball is shaped slightly differently and there's an extra part to that, it's very easy as the ball is moving around within the socket to make contact with the edge of the socket. And inside of that socket, we have a ring of cartilage, which kind of creates that suction cup type of effect. That's what your labrum is when we refer to that. So the pinching then happens on that ring of cartilage. So that's from the ball itself being slightly differently shaped. You can then also have a sort of overgrowth of the acetabulum, so the cup itself. So almost think of like an extended lip of your cup, so to speak. And that can also then cause impingement in the other manner. So again, the ball meets the edge of that acetabulum, that cup, a bit quicker. And well, quicker is not necessarily the right word. Quicker or slightly differently, which causes a pinching again of the cartilage within there.
Yep. Okay. That is very clear. With regards to the sort of what you can do to either manage those symptoms or, prevent that from happening, is there anything, I mean, as you said, in some ways it's a relatively inevitable injury, especially if you have either a cam or a pincer deformity. And so, I mean, historically, when I've treated this type of impingement problem, it's very much about stabilizing the hip, making sure that you've got really good strength around the hip and the pelvis. So I'm assuming it's something similar that you would do with your strength athletes.
Yeah, the predominant thing is looking at control around the hip. Quite often with these, there is, once a sort of labral tear has happened, if that is the sort of thing that brings them into clinic, there is already a sort of loss of stability that happens with that. And that's also natural with sort of inflammation and pain anyway. But then we have to really get to the crux of actually, is there good control in all directions around the hip? And is there good synergy as well between that sort of core engagement at the same time as, when you're in that deep squat position? Because yes, there is control around the hip, but actually, where are you then allowing most of that loading force to go? Are you supporting that load with good core engagement as well alongside that, as well as control around the hip? Or are you compensating when you're sort of catching the weight because you don't have the core engagement, so you're then compensating at the hip and creating sort of more contact through surfaces? The body's so clever at adapting, so it will do whatever it needs to do to get you through what you're asking of it.
Yeah.
And so that's why I always sort of say to people, it's not a problem until it's a problem, because eventually your body will reach its ceiling and go, actually, I can't keep doing this. Here's the pain to prove that to you. But yeah, control around the hip is a key thing. And another key thing is the actual mobility around the hip itself. So with the hips, with shoulders as well, this is completely relevant. What we tend to find is, one, given our lifestyles, that's obviously a huge part of that. Most people's sort of jobs do dictate that they spend a lot more time sitting and not moving around so much. And two, dependent on your previous sporting history and how you end up within the strength sport, you may find that there's already been a restriction in your mobility that isn't necessarily because of, that cam or pincer lesion. It's something that's just become a little bit stiff and doesn't move that well. So there's a lot of talk about internal rotation, and I think sometimes external rotation of the hip gets neglected. But yes, we do know that quite often internal rotation is the movement that people struggle with the most. So we're looking at the mobility of the hip and how it moves in general without actually considering the muscular control. And then we're looking at the muscular control around the hip. Do the hip flexors work well? Are the glutes doing their job? Are the adductors also coming into play? Or are they too tight? And then on top of that, what is your proprioception like through the whole lower leg? That's something else that I think is not often looked at enough. We kind of go, oh, okay, yeah, they're strong in this muscle, but actually, can they even do, a single leg knee bend, or can they actually do single leg balance for more than 20 or 30 seconds? All of those things play into ultimately your stability through the whole chain.
Yeah.
So yes, we want to look at it on a very specific level in terms of control around the hip and with that the pelvis, but also then we want to look at the bigger picture as well.
Great. And then let's move on to the sort of next category that you were
So the
talking about.
compression.
Yeah.
Yeah. So yeah, the next one I sort of lumped together under compression related issues. And this is where I would say predominantly you tend to see more of your back related issues.
Okay.
I think one of the very beautiful things about strength sports is that we don't see as many back injuries as people have previously thought. And I know that that's a big factor as to why people sometimes feel like they don't want to go into strength sports. But actually, predominantly, it's those strength sports that will make your back probably the most robust it's ever been in many ways, if done correctly. But we do still tend to see that there are things like facet joint irritation. That's quite a
Yeah.
common one.
Yeah.
It's really important to make that distinction as well. A lot of people will come into clinic and go, I think that's it. I've done a disc and I think that's over for me and this sport now, or these sports now, whichever one it is that they've sort of come from. And actually quite often it's not, it's more of a compression related issue. And the most common one is sort of that facet joint compression. Outside of that, there is obviously the occasional disc injury. We do get some disc bulges, some disc prolapses that do happen. That's inevitable in life, not just in weightlifting, but I wouldn't say they're as common as they are with those that come in with disc bulges from not training at all, actually.
From
And
sitting at a desk all
yeah,
day.
yeah.
Yeah.
So, sadly, I think, if I had to persuade people, I would say you should definitely be doing strength sports if you want to
You
try
have a
and sort
bad
of keep.
back. Yeah.
Yeah. Obviously, there is the longer term compression related issues. So quite often, people will come back, especially from having a scan, for example, saying, these levels of discs within my back are dehydrated, or they are, there's more compression at that level because the disc is thinner in that area. But to be honest, I tell most people when they come into clinic, in reality, if you have done some level of sport, from a young age up, probably by the age of sort of 25 and up, if you've done enough sports by that time, you probably do have some dehydration or some compression in your back anyway.
Yeah.
So, yeah, I would say commonly it's normally facet joint inflammation and or compression and maybe some disc dehydration.
And do you find that it's mostly lumbar or cervical, or where is you were talking quite a lot about sort of this thoracic spine being quite stiff,
Yeah.
but often stiffness is, it's not that it's a good thing, 'cause it sort of reduces sort of movement and things, but it's probably less likely to get
Yes.
injured, whereas the lumbar spine perhaps and cervical spine are a bit more prone to injury.
Yeah, I think predominantly it's always the lower back,
Yeah.
realistically. The lumbar spine is the one that tends to be, well, obviously, given the nature of the sports as well, it's the area that is most compressed. I will say with powerlifting, due to the way in which they squat, occasionally you will get sort of more commonly, you may get still some irritation through the thoracic area. So it's a bit difficult to explain clearly if you haven't seen it perhaps in action, but in weightlifting, we do high bar squats, which means that the barbell predominantly sits on our traps, and we have a much more upright torso. Oh, that was very northern. Upright. We have a much more upright torso, even given sort of limb length. That's how the squat mechanics will be in general. With powerlifting, it's a much more hinge-based mechanic, so
Okay.
they tend to roll the bar right down to around T4-ish, T4, T5. And it's very, very intense because the way they have to grip the bar with their arms means they have to lift the elbows, and essentially they're pushing the barbell into their back to keep that weight on their thoracic. So their squat doesn't tend to be so much of a straight up and down motion. They actually tend to hinge forward quite a lot at the hips. So you will see that they don't go below parallel in the same way as weightlifters do when they squat. And so because of that, there are sometimes those more thoracic based issues with powerlifters.
Yeah.
But I would say across the two sports, predominantly it is lumbar. And that's normal. Ultimately you're asking your lower body to take the significant load, and lumbar injuries or lumbar issues, they don't just come from necessarily compression of the lumbar spine alone. They go back to things that we said about before. So things like your hip mobility and is there any alteration in your mechanics at the hips because of, like we said, cam, pincer, or control around the hips? And so that's where we also look, like with every physio assessment, from the top down and from the bottom up, and consider all the joints that are affecting the loading of your spine.
Yeah. And is there anything that people can do to kind of prevent these injuries, or is there anything specifically that you would do to treat those injuries? Obviously, as you've talked about, looking sort of throughout the whole of the body, but are there any other treatments that you might look at doing for somebody who's come in with a facet joint irritation?
Yeah, I mean, with facet joint irritation or compression related issues, when it comes to those in strength sports, but actually, even actually if a runner came in with that, I have a very much, like, what's the word I'm looking for? It's a very matter of fact approach. I think you have to be very clear with people. Education is such a huge part of that. So quite often, if it is a disc injury, people really don't feel like they've necessarily been educated on what that might look like a month, 6 months, or 2 years from now. And that really good understanding of the fact that to some degree discs do heal. Quite often people are like, that's it, my back is gone, it will never be the same. And so this is where, obviously, looking at the psychological side of the psychological impact of that, having a really good understanding of what your injury is and what that looks like going forward for you and your sport and your movement is really, really key. So that's the first thing. The second thing is, I make no bones about getting in there when I'm doing my manual therapy. There is, a lot of back and forth with evidence about whether or not manual therapy techniques work to help with facet joint issues. I can say, honestly, clinically, I've never had anyone sort of say once I've mobilized their back that they didn't feel that movement was easier or better after that. And obviously, as we know, if something is easier, hurts less, and they feel like they have improved range of motion, then people are most likely to go away and do the rest of what you're asking them to do. And that is the key part. If you don't engage with the rehab, then we're going to have that discussion next time you come back into clinic, because that is something that, is going to make the biggest difference for you. And I remember about probably when I first started my sort of own practice, I was very big on sort of teaching people, yes, range of motion in all directions after a back injury. Spines, they like to be moved in all directions. So when that sort of guarding and protection comes in, because we're worried about damaging our backs, quite often we're compounding the problem and prolonging it. So I definitely teach sort of all range of motion very, very early on in whichever manner we can get it, I'll take it. And then after that, I'm actually really big on teaching spinal flexion with movement. And that is for the decompressive element, but also for the strengthening element. So, a lot of times, a lot of the spinal loading that we do is what we would call in the more extended position. I think when if they were to look at the spine on scans, actually in your flexion or extended position, we're never as flexed or extended as we think we are through the spinal range of motion. But I do also teach a lot of spinal flexion with weight, and that allows you then to sort of create decompression in your own back, so to manage that feeling of compression and stiffness. But it's also going to strengthen all those things that we're a bit less likely to strengthen if we restrict our range of motion. So, for example, the ligaments between each area of your back, actually stressing the discs in a different way and creating some more strengthening through those. We know with things like loading tendons that we're strengthening those. Ultimately, the more load we put through them, the more responsive that tissue becomes for handling those. And it's the same with the spine as well. There's no reason to sort of wrap it in bubble wrap and not do that. And it also really helps to account for when lifts are not perfect.
Okay.
Which they're not always perfect. So why would we not train weighted movements or through full ranges of motion at the spine, just like we would at any other joint?
Okay, that sounds good. And so just moving on, I'm just a little bit conscious of time. No, not at all. It's been great chatting. But the final category, do you want to just go into a little bit more detail about that?
Yeah, so there I sort of said the sprains and the strains. To be honest, the reason that they happen less is quite often they tend to be bigger injuries that cause those sort of tears or sprains to the smaller ligament groups, so around the wrists or sometimes around the elbows. I think one that classically, like everything, one that sticks in people's mind quite classically is elbow dislocations. They happen so rarely.
Yeah.
But obviously when they do, quite often then that's a tear.
Pretty traumatic.
Yeah, and a tear at some major ligaments at the elbow. But they really don't happen as much as you would think. It's just that those ones are 9 times out of 10, they happen to have been televised. And that's the one that sticks in people's mind. But we do get some strains around the elbows and around the wrists. The other common one is off the back of the strains around the wrist. Of the sprains around the wrist, sorry, not strains, sorry, I should say, is a ganglion cyst, which sometimes comes from compression as a result of those slightly more lax ligaments around the wrists. But again, they're just not as common as the other injuries. And in terms of muscle tears, again, they tend to be those sort of big catastrophic events if they do happen. I don't know if I'm scaring people, but I did see there was an American lifter, doing his lift as normal, caught his clean, stood up to jerk, went to jerk, and both of his quad tendons ruptured.
Wow. Oh, gosh.
Yeah. And
That's
so,
quite full on.
yeah, that is something that, it's like I said, it's quite a catastrophic event. They don't happen as often. With the muscle tears or strains, I'll be honest, don't see them that often. So with the muscle tears or muscle strains, they're not as common as you would think. And again, that all comes down to generally you will have a coach within these sports and they will progressively overload you. So, the demand on your body is relevant for what it can sort of manage at the moment. And then you progress that accordingly. So yeah, muscle strains and tears, not a very common one.
Okay.
No.
I was sort of thinking again, more sort of the recreational end of
Yes.
conditioning, maybe things like sort of biceps. Do you ever sort of see more kind of strains around sort of long-headed biceps, or
Yeah.
I
I
guess
think
sort of again the sort of shoulder and upper limb? Maybe I'm just sort of thinking of, again, it's a bit stereotypical, I guess, but the sort of the guys that you see in the gym
classic
who,
bodybuildery.
yeah, who are sort of lifting too heavy weights and
Yeah.
with poor technique and that sort of thing.
Yeah, I think you're right in terms of recreational strength training. Definitely would say that you're more likely to see those muscle strains happening there. Again, tears, not so much. There has been the odd occasion where there's been a pec tear or a bicep tear. Actually, if anything, I probably the most tears I see is quite often something like BJJ, to be honest with you. But
Okay.
occasionally in your recreational sort of strength training, yes, you might get quite, again, a bit of a catastrophic event really. When it goes, and you'll get a bicep or a pec tear commonly. Do I
Yeah.
see many in the way of quad tears? Not really. Bicep strains, pec strains, and occasionally hamstring strains in recreational training. But yeah, I wouldn't say it's probably not as bad as it has been before. I think a lot of people now do focus quite heavily on technique. And sometimes it's just the nature of overloading the muscle. If you are training for a bodybuilding show, the sheer volume that people put through very specific muscle groups is more likely to lead itself to a strain.
Strain.
Yeah. But it's, yeah, a bit 50-50.
Okay. Okay.
Yeah.
So I think we've sort of, let's come to a bit of a close, and it's been really lovely chatting to you, and lots of
Thank you.
information, lots of really useful tips and things for our listeners.
Yeah. I think in terms of things that people can take with them into either their specific strength sport or into even their recreational training is, one, never rush. And predominantly that's dealt with by a good coach if you're in one of the main strength sports. But if you don't have one, think of the idea of, or the principles really of strength and conditioning, which is your progressive overload and your periodization, which essentially means do what you can until you're able then to progress that. You are not losing out by lifting a weight well regularly for 6, 8, 10 weeks. You can progress that when the body is ready to take on more. So don't rush that part of your strength training. The other thing is with spines like movements. Even if you have had a sort of spinal injury previously, don't be afraid to move in all directions and really start to get to know with your body what is pain versus what is discomfort from something I haven't done in a while or I've never done before. And I think really you can carry that across to all aspects of working on sort of mobility or strength training, for example. And the other thing is don't be afraid to load your injuries again during the recovery process. And I say that more specifically actually with like the tendonitis and the tendinopathies. But one of the things that we miss is appropriately loading the muscles when we're coming back from those issues. And ultimately we need to do that to prevent further injuries at the tendons again. But the same thing would apply with the spine as well. Don't be afraid to load those. So most of it is really make sure you understand your injury if you are injured, make sure you understand it and make sure you understand what the plan looks like for coming forward from that, and understand that movement in any form is always going to be the key, even if it feels a bit scary initially.
Okay, well, it's been really lovely chatting to you, and just remind everybody where they can find you, and if anybody is wanting some more advice or wanting to come and see you because they are injured, where can we find you?
Yes, so you can find me in Spitalfields, so a few minutes walk from Liverpool Street, or in Victoria, and again, it's a few minutes walk from the Victoria Underground, and both of our locations are listed on our website.
Great. Well, lovely to speak to you, and hopefully we'll catch up again soon.
Yes, thanks for having me.
All right, take care.
Bye.
Bye.
Thank you for listening to LBSM's Ask the Expert series. We really hope you enjoyed listening. If any of the topics discussed are relevant to you or you want to find out more, please get in touch by phone, email, social media, or visit our website. Thanks again, and see you soon.